This is my ATTR 810 spine reflection. Overall, I'd rate myself probably on a scale from 0 to 10. I would say either a 5 or a 6. I guess I can kind of compare that to an ankle eval. I would probably put myself about an 8 or a 9. I don't think anybody, at least anybody that I know, is a 10 out of 10. Because there's always room for improvement and areas of growth, and there's always new evidence coming out. So I'm not sure that I'll ever be a 10 out of 10 in any area of the body, just because there's always something new to learn. There's always a new approach. There's always a new special test. There's new research coming out on the diagnostic accuracy of those tests. So I would say either a 5 or a 6. My strengths in the spine evaluation process, I would say, is talking to the patient and taking a comprehensive history. I feel like at the spine, it's a bit of a high-risk area, so I definitely take my time the most at the spine. I would say it's not a huge problem if I misdiagnose a grade 1 lateral ankle sprain rather than a grade 2. I don't think it's the same case at the spine. So I would say I definitely take my time and seriously think through what's happening at the spine. And I definitely follow up with the patient and reevaluate multiple times, just in case there's something I missed. When we reflected on the ankle, one of the things that I said I wanted to improve on was reevaluation, because really with an ankle, I do feel confident, although I know that there are room for improvements. However, I don't usually reevaluate 48 or 72 hours after the initial ankle sprain. I do that with the spine, probably daily, if not every other day, just to be sure, just because it is a high risk area. I would say another strength at the spine would be the use of patient-rated outcome measures. In the fall, I implemented a new PROM with a symptomatic patient. She had facet dysfunction. She had opening and closing issues. So I got pretty comfortable with the neck disability index. So I would say that's one of my strengths, is using that information to guide sort of the next steps of my evaluation and get more information from the patient. I would say my weaknesses are coming up with a differential diagnosis. I do not have much experience with evaluating the spine, other than mock evaluations, or the hip or SI joint, differentiating between that. But I would say I am confident with diagnosing facet dysfunction and also treating the opening and closing, just because I've had so much practice, and I'm confident that I can diagnose cervical radiculopathy, but really that's simply because that's where my experience lies. So coming up with a differential diagnosis that is not those two pathologies, I definitely can improve on. Another weakness, I rarely, if ever, assess posture with really any of my evaluations, which I know is definitely a problem, but particularly at the cervical spine, thoracic spine, lumbar spine, really any part of the spine, I understand how crucial it is to evaluate posture and take a plumb line measurement and then work to correct the posture, or ask the patient what they're doing in class. Are they slumped over? Are they sitting up straight? So I definitely need to do a better job at going further and not just using my special tests and my manual MESA tests and palpation, but going further, assessing gait, assessing posture, and recording those measurements as essentially a baseline. I would say the one thing that I do in my evaluation of the spine that's most useful is undoubtedly the use of a patient-rated outcome measure. I've found that since we've implemented PROMs since the summer, I would say 70% of the information, the crucial information that I gain, is by asking probing questions after I receive the information on the patient-rated outcome measure. So using the quick dash, and I say, oh, you're having trouble washing your hair in the shower. Can you tell me a little bit more about that? I would say that's the most useful to guide my clinical decision making, especially with an NDI. What areas would I like to improve on? Really using the best tests in terms of diagnostic accuracy. After I learned the highest sensitivity specificity of the shoulder special test and the SI special test and that cluster, it has definitely changed my clinical practice. I don't waste my time with special tests that simply don't have good diagnostic accuracy or don't measure what they're supposed to measure. So I would like to become a bit more confident in special tests at the spine, but also the diagnostic accuracy associated with those special tests. And also just my general confidence of my approach to the spine. For some reason, I think myself as well as some other clinicians just have this fear when evaluating the spine. And we talked about a lot about this in manual therapy, where we're kind of hesitant to apply the opening and the closing and the unilateral PAs and the central PAs onto a cervical spine because, to be honest, I thought I was just going to dislocate something. But once I practice on my classmates and I practice on, my peers, I then applied the techniques, and now I do them all the time, almost every day, without even hesitating. So just general approach to the spine. Also, areas of improvement would be just my neurologic assessment, doing all of the upper limb tension tests, and also understanding which one of those have the best diagnostic accuracy in one of the articles that we read this week. So my definitive steps I'm going to take to improve my clinical practice before our standardized patient, I would say, is to make an effort to practice on my peers. Take some of the tests that we read about this week and all of the upper limb tension tests and practice them on my peers before just going out and applying them to my patients. And we learned a lot about McKenzie technique and the flexion and extension exercises. And although, as the podcast clearly stated, it's best to be certified in McKenzie exercises, but I think that athletic trainers across the board can benefit from some of the from the concepts. So just having conversations and practicing with my clinicians before actually applying them, I think would be my number one definitive step that I plan on taking.